4. All right, we are live. Welcome to Fresno County's community planning process for our Mental Health Services Act annual update. I'm Ahmad Brahmi. I'm one of the division managers here at Behavioral Health, and my team and I have been working on our MHSA plan and annual updates for the past couple of years, and so we are continuing that process. So if you're joining us or if you're just getting on, you can watch this 3 ways. You can participate by logging on to Facebook if you have a Facebook account, and you can watch there and or also put comments or questions in the chat. If you don't have a social media account, you can watch this easily with no additional requirement by just watching it on our YouTube page. However, you will not be able to put questions or comments if you don't sign in. And then the other one is you'll see on all the chats on both Facebook and YouTube, as well as the email information that went out earlier. We have the Webex link, which you can click on that and you can watch that as well. The Webex link will allow you to, later on when we get to the input session, for you to be able to ask questions or comment verbally. Otherwise, you can always submit comments and questions through the chats on the social media. We also will have information at the end of this where you will be able to, for gosh, I don't know, at least the next few weeks, email questions, comments directly related to our annual update process. So for those of you, if it's your first time, we're going to go over some things that we've done in the past. For those of you guys that have been part of our annual updates or MHSA 3-year plan, this PowerPoint will be familiar to you. We'll go through these slides fairly quickly, and for no other reason than we want to make sure that we devote as much time as possible for the community input. So the slides are more to give you some context and information on who we are, what this process is, and what the annual update will be seeking to achieve. So with that said, I'm going to go ahead and get started on our information here, and I should probably move to, I'm going to go way to this side. Sorry, guys. So if you see on here, this is just information about what and who is behavioral health. So we are a county department here at Fresno County Department of Behavioral Health under the guise of Fresno County. We're primarily charged with providing the mental health services and substance use services, broadly known as behavioral services, for the residents of Fresno County. Those can range from treatment services, education services, prevention services, a wide array of those in both the mental health and the substance use side of the field, if you want to call it that. We do provide services primarily to individuals who are Medi-Cal eligible, underinsured, or uninsured. That comes more for the treatment side of it. Or when it comes to like prevention and education and things of that sort, those are broader, and so they really are utilized to serve all of Fresno County and all of our residents. Our services range from ages 0 to end of life and everything in between. So we're not an organization that has a specific area, nor is our system of care that we operate specific to any age group. So Fresno County Department of Behavioral Health does not provide services by themselves. We provide services through what we call our system of care, which is made up of 100+ different programs, 70 different contracted vendors, and community-based organizations, as well as ourselves. So what is the Mental Health Services Act, or as you're going to hear me say this, MHSA. So MHSA was actually a proposition approved by voters, as you'll see on here, in 2004. At the time, it was Proposition 63. I'm covering the logo, but trust me, that's 63 on it. The state only has so many numerical options, so after a number of years, they start to recycle their proposition numbers. So the reason we'd like to use Mental Health Services Act versus Prop 63 is that number could be recycled in the future for other initiatives and ballot initiatives or causes. So best way to refer to it is MHSA, Mental Health Service Act. So Mental Health Services Act, so that you understand, is a 1% annual tax on incomes over $1 million. So if you have an income one year, you do really well and you work a lot of overtime, or you get a sweet bonus and you cap out over $1 million, you will get taxed at 1% for that year, and that money will go to MHSA. But if the next year you only make $999,000, you will not be taxed that 1%. So it is based on a 1% tax on millionaires. So if you happen to be a millionaire for 1 year, you're going to get taxed. If you go back to not being, you'll be fine. There's not too many of us that are millionaires, but for the millionaires in the state, they do drive this particular funding source. The thing to be aware of with this, because it is tax-based, the funding source for it makes it volatile. So times where we're dealing with a recession, times where there's an economic downturn, if, you know, a bunch of millionaires move out of state, things like that, it can have an impact on what the monies counties get. Usually that money is so the money that is generated this year will not come to counties till 3 years later, but it does drive our funding is driven by basically the success and positive outcomes with our local economy. So the money is meant to provide community-based mental health services, and that's really important to understand because the focus on this is that community-based. It's not to invest money for hospitals. It's not money for mental health services to be provided in jails or prisons or institutions. It's really to be ensured that these are provided at the community level. The services are supposed to be developed with community input, and that's why we have these types of processes. If you guys remember, a couple years ago when we were doing our new 3-year plan before COVID, we had over 20 community sessions all over Fresno County, different dates and times. And so that was really something that, that we want to make sure that we do. And that's why we're trying to do these virtually, but also trying to utilize some of the technology that will allow for more input. MHSA plans are kind of set for the 3 years, and then we utilize our annual updates such as this to then address any changes or adjustments. MHSA, I mean, it was used to close the system gap, but the term that I've heard a lot of times, and I think really speaks truly for Mental Health Service Act, and that was for it to be transformational, to be really transform our system of care to become more of a person-centered, focus on recovery and resilience and wellness, including those prevention aspects of it. So it's really a transformational initiative. And then the last thing I just want to note is California is the only place in the United States that we have something like the Mental Health Services Act, which is really funding that comes in that allows us to do things like prevention, early intervention, education, workforce development, provide a lot of those supports. So we're fortunate in that regard here in California. So there are 5 components to the Mental Health Services Act. You'll see on there are the 5, oh, I got to go to this side. Sorry, Brian's directing me. Thank you, Brian, to make sure that you guys can see the words here on there. Images are made up of 5 components. You'll see them on the screen: prevention, early intervention, community supports and services, innovation, workforce education and training, and capital, facilities, and technology. Now, what you can do is if you go to www.fresnomhsa.com, you'll go to our MHSA page, and we actually have 5 short videos. They're about a minute and some change that will kind of dive into each one of these strategies and components of the plan. For more info, I will give you just really a brief overview. So prevention, early intervention, those are 2 different things. Prevention and early intervention is actually made up of 6 strategies, is what they call it. So the strategies are prevention, suicide prevention, stigma reduction, outreach for recognition of early signs of mental illness, access and linkage, and the last one, early intervention. Early intervention, that part of it can sometimes be a misnomer. People lump prevention, early intervention together. Prevention varies from early intervention, and early intervention is really talking about a diagnosis. So diagnosis is necessary for that service. The other thing with prevention, early intervention, it's a great way for us to address gaps in our system of care, a great way to address some of our health disparities. It also requires that 51% of the funding be spent on youth. And so we have successfully done that over the years here in Fresno County, which we're really proud of. The second component, community supports and services, are made up of 3 areas. The highest is the full service partnerships, or FSPs that you hear about. Those provide a full range of whole person care, not just the clinical, but any medical, the wraparound, all of those things. The second component is systems development, which goes into maybe some of our housing programs, some of our outpatient programs. And then there's the O&E, outreach and engagement. And that outreach and engagement is a little different than the outreach in our PEI component. So there's a lot of codes, regulations, things like that around that. That's why I say if you go through the video, it gives you the videos on our Fresno MHSA page. It'll give you some additional info for myself and our team that handles some of our MHSA. Trust me, there's pages and pages and stacks of regulations and codes and definitions that we constantly have to review and double check and make sure we're listing things right. So CSS is about 77% of our total MHSA. PEI is about 18%. The innovation, the third item on here, is made up of 5% of our MHSA dollars. It is one-time dollars. It is for 3 to 5 years, and it's really meant to be pilot testing, research. Historically, some counties had utilized innovation as a way of doing new programs. We strongly advise against that, and so we don't do that, because the problem is if you have $3 million to spend and you say, you know what, we're going to start this new program, we're going to spend $1 million a year on it. The problem is if the program is effective and really having an impact, once your innovation funding sunsets, you then have to find a way to sustain the program. So it's not a good way of using it as seed money. It is a good way to pilot and test certain initiatives. It's a great way to do some research, get more information, assess systems. So those are things that we want to make sure that we're doing with innovation. Workforce education and training, or otherwise known as WET, that's money that is utilized for just that. Right now we have a new WET plan that is out, and I'll touch on that a little bit later, that's looking to utilize some of the funding from that for scholarships, loan repayments, career pathways, and now there's a proposal to statewide to see if we can utilize that also for some retention efforts. Last is capital facilities and technology. Very narrow use for that. It's very narrow in terms of what you can buy, what you can invest in terms of capital facilities, how the money can be used. The technology part where we've been utilizing locally to try to work with improving and updating our electronic health records and some databases so we can do a better job of providing those services. But that's an area that also has some really specific caveats for it. And the WET and the CFTN monies from the state have basically at this point sunset. And so as counties invest in those areas, they're moving money out of one of the other two components to invest into their, well, actually, number two, their community supports and services, to invest in those areas. So do I need to go to this side now? All right, I'm going to this side. And we're moving. All right, so what is in the MHSA plan? So real basically, and simply, our MHSA 3-year plan is developed every 3 years, and in between those 3 years, we do annual updates. It's really more of a blueprint to help us guide and identify what are the services and resources we're going to provide with our MHSA funding, making sure that we're trying to close gaps. And so that's really what the plan is. And then once we have the plan, we have to stick to that plan unless we're coming back and doing an annual update, such as we're doing right now. Or if there's something specific we need to change, we do then need to bring back to the public, go through a public comment process, public forums, hearing, and discuss that with individuals, and providing at least 30 days so everyone gets a chance to be heard and spoken. So right now what we're doing today is kicking off the first of 4 community planning processes that we'll have. There'll be another one in English next week, I believe. We have one coming up, I think Friday in Spanish. In Spanish, we have another one next week in Hmong and another one in English. And these again are just the beginning. There'll be opportunities for people to comment throughout. We'll then take that information, try to develop a plan, come back with a report session, and before the clock starts for 30 days, we'll have a number of other feedback sessions with the community. So this is a little different for our annual update, so people will have plenty of time to provide input and have the discussions. So I just want to make sure that people don't feel like there's only 4 sessions. Like, no, there'll be multiple sessions beyond that to report back what we hear. So what is DBH continuing to do in the 22-23 plan? So I'm going to glance at my notes right here, just because these are things that are very specific, and I did not want to memorize them, nor did I think it was really effective to memorize. But some of the things that we've done in the past year and we're continuing to do is right-sizing programs. So by that it means we're looking at programs. If a program, for example, is budgeted for $100,000, but they're only spending $70,000, and it's not because they have had vacancies or anything like that, but the program just is really efficient, let's say. Then we're looking at, hey, can we adjust that program to then be $75,000 and utilize that money that's being tied up in the budget to offset some of our costs or reduce our overall costs within some of our MHSA components. We're looking at how programs are funded. MHSA is supposed to be the funding of last resort. I think because in years past we all had money and MHSA money, so we utilized MHSA to set up and fund a lot of programs. But now we're really looking at is MHSA maybe the best way to fund that? Are there other ways that we could potentially fund that? And either reduce our MHSA costs, and by reducing our MHSA costs, allow us then to have money to develop new programs, or to maybe shift that funding to expand and grow some of our other programs that are being effective. We're also continuing to evaluate and assess our programs. We finished evaluation of probably most of our PEI programs. We have a couple other ones that we've now started. We're looking at internal and external programs through MHSA, so we're doing a lot of evaluation. We are recommending deletion of 3 programs, and so let me clarify what I mean by deletion right off the bat, because I think that's going to be important. So when we say deletion, these are deleting programs that appear on paper, but they're not active programs. They've never come to fruition. By us deleting these programs, no individual in Fresno County is going to get less services. No individual is going to lose the services they're receiving right now, and no one's going to lose their job. So what we're doing by deletion are ideas and programs that had been put in our previous 3-year plan, had been carried over to this 3-year plan, and either just because of capacity, some of it is funding, some of it is just leveraging other resources and maybe new demands, the programs have not come to fruition. And so at this point, we're looking at deleting them, so we're removing them so they don't kind of linger. We can always come back and add them in our next 3-year plan or if things change, but this allows us to shift our attention to really working on the programs we have right now. And so the first one of those is the ACT team, which is Assertive Community Treatment. Thank you. I was just like, Assertive Community Treatment Team. So we have an ACT team for our TAY population. We don't have an ACT team established yet, and that was one of the things we were looking at. However, we do have a number of FSP programs. We have designed and written some of our FSP programs to really model the ACT model, to provide some of the higher intensity care for the individuals. And then as we're looking at trying to implement things like assisted outpatient treatment, otherwise known as AOT, we're really looking at how can we leverage some of these existing programs to address those needs versus trying to build a whole new program that could potentially still address the issues or where other programs could address those needs and issues. So that's one, just because in almost 5 years now, we've not been able to get an ACT team up and running, and it's not because there wasn't an interest, but it's just capacity-wise and our ability to take on such a large-scale program.
No funding changes to the TAY program.
Correct, and there's no funding to the TAY program or that ACT team. This is us again. If we haven't been able to do it, partially because each year we look at, do we have money to start an ACT team? No. So if year after year we don't have money to start an ACT team, it probably makes sense to maybe look at something else for now. We can always come back and visit. The other one is there was a continuum of care for persons affected by human trafficking. So when I say continuum of care, that means the entire continuum, from prevention, early intervention, and outreach and engagement, all the way to like the high intensity full service partnerships for individuals. And so this was a project that the county had considered a couple years back, even went through an RFP process. The RFP was rejected by the panelists. We came back and really tried to start looking at what were the options for that. We were looking at cost, what was being proposed versus what was available and feasible, were all challenges. And then we've also been dealing with COVID. We've also seen a changing dynamics in the landscape, so more resources and services where we think we could address and close those gaps without creating a whole new system, continuum of care that right now, again, would be challenging. Again, doesn't mean we can't come back and visit these in the future, but those are one of the programs that we're recommending deleting right now. And like I said, deletion is not terminating or eliminating, because it's not a program that exists in anything other than an idea on paper. And so the last one that we're looking at recommending is the wellness activities. And so the wellness activities one, let me go over here because I'm blocking, I guess, the words, but not a lot of, so hopefully you've gotten those words. The wellness activities was in our previous 3-year plan. It's been 2 years in this plan, and we have looked at it and we realized that over the past 3-4 years or so, correct me if I'm wrong, like it's been in there, but it has nobody's charged it, nobody's used it. And so in a time when, where we're looking at, potential financial constraints and really how do we become more efficient and effective with our dollars, it doesn't make sense to have a program on paper that's funded and yet no one is used in the past couple years. Not that there's not a need, but we have found other ways to support that need. So again, MHSA being a funding of last resort, makes sense for us to maybe move that allocation or move that someplace else where we can have a better impact. Actually, that just gave me an idea, but we'll discuss off.
And Ahmad, so one of the questions I think it'd be good to address now, so what about the ACT asking for the Justice Diversion Program. I'll just clarify, this only affects the adult act.
This was an ACT adult program that has never come to fruition. It exists on paper only as a placeholder almost. And a couple of times we had looked at trying to move forward with an RFP on it, and it's not come. So it's not eliminating anything that currently exists. Like I said, no existing program is being impacted by these deletions. These are more ideas and things that we wanted to achieve that we just have not been able to. So yes, thank you. Good point, and a great time to kind of address that. One of the things we're looking at with programs is funding, how the programs, again, like I said, are funded, and the sustainability. So that means like looking at some of our programs that could be drawing on things like Medi-Cal. Are we doing that to the full max? Are there opportunities for us to improve in that? Looking at our billing, and some of it has to do with, billing timelines of hey, once we get that in, what will it actually look like? Do we actually have more revenue coming in than we think? And does that mean like that's great because now we can shift some of these programs, or we can raise the max amount of contracts and things like that? But at this point, we're keeping things as they are, and pretty much most of the things you see in the plan in terms of contract amounts are estimates based on MHSA, and they're estimates based on what we believe we've gotten in the past on Medi-Cal. They're not actuals because those require us to get more information and a couple more history. Go this way? Okay. Thank you, Brian. So like I said, funding and sustainability will be definitely consideration for us. So it's like if you guys have some great ideas and we get 5 great ideas today and say, hey, you guys should do these, we're gonna have to really look at, can we float 5 ideas? Can we float at 5 ideas for more than a couple years? Do we do one idea that really is gonna address a gap or really improve services? Or hey, can we leverage maybe a program that already exists, and how could we maybe expand it to address that need? The other thing, and as far as what we're continuing to do, we have 9 innovation plans approved. We have 7 that are active plans right now. We have 1 that is set to come on board or go live, I want to say in like the next month or so. And there's 1 remaining one, which it is one of our transportation projects, if you may recall, which because of COVID, we do have concerns about implementing. We do not want to put multiple people in cars, tight spaces, and have them, traveling distances. So that's one program that has been on hold. But of our 9 approved, 7 are active. 8th one is coming online. If you go to that same FresnoMHSA.com website, as I mentioned, there's also 4 annual updates for 4 of our current innovation plans that have been around for more than a year or started in the previous years. And with innovation, because those projects are specifically for learning, that specific objectives, and they're approved that way, with our annual updates, they're really more of reporting out what has occurred thus far, what learning maybe has come about, and what is planned in the upcoming year. But there's not a lot of divergent on those, because again, if you start to move and change things midway, then you're kind of changing the innovation plan and also either the research premise or the learning premise. But definitely go check those out. There's some information in those as well if you want to see what has been going on up to then. And we're going to continue working on AOT. So Fresno is one of the counties that has opted into assisted outpatient treatment, AOT. And so we're continuing to work on that. There are a couple facets to that. There's the legal and coordination and outreach facet, then there's the actual treatment facet, and that's again where we're trying to work those out and also leverage some of our existing FSPs and some of our other programs of how can we utilize those for the treatment component, and really how do we engage some individuals who maybe need that specific, how would you say it, as assisted outpatient, a system a little more a system with a little more persuasion into care and treatment. So those are some really big projects that we're looking at. And so because we've got those, we're also looking at, hey, again, how can we leverage and how can we support maybe the AOT, well, not maybe, how do we support the AOT and making sure that we have resources to support that versus, continue, like I said, have some programs on the books that we've never started, that we've never been able to really get up and going. And so those are some deletions and right sizings. Like I said, but what we're doing right now is trying to avoid really impact on active existing programs. Should be done here in a second. So what plans do we plan changes in the plan? A couple of things to just be aware of. Like I said, AOT is something that we're looking at. How do we really leverage some of these programs to support that? So those are things we'll be looking at and hopefully reporting back out. CFTN, really looking at how do we address some of the electronic health records and data. And some of the work with that is really coming up with new EHRs, electronic health records, that'll match the payment reform that's happening statewide. Things like CalAIM, better care coordination, and counties are looking at maybe coming up with something that several counties will at least go in and invest. And so that way, as you have individuals maybe traveling across counties or as they move, they'll actually be in the same system versus, you know, something completely different. So some of those things that we're looking at with terms of integration. I touched on, you know, continuing to look at right size. One of the things I do want to note that just came up a couple weeks ago or more recently, the state, and I think it was Cal FHA and SNAP gave Fresno County back $206,000 one-time money, and it has to be spent by June 30th. So we have about 6 months to spend about these $200,000. That'll be one time, and I can't. Yeah, that has to be related to housing, and I believe if I remember from Tammy, it was interest related, or so it was money that we didn't even know was out there, and they go, oh, here's the money. So one of the things that we're going to be also discussing is how we can best use that. One of the possible considerations with that money, because it is one time, it is $200,000. Would be, could we utilize that to assist with a number of these housing programs that we have coming live in this year, that it could be utilized for deposits, maybe first month's rent, moving costs, to be able to help move people into some of these new housing programs. I'm not sure if that would still cover all the costs and there would be money left over, but those will definitely be things that we're looking at, ideas based on what we understand in terms of how we can use it, and to have that vetted by you all as well. I'm trying to think if there was anything else in there. Oh, the WET plan. So one of the things that might be changing with the WET plan, and this is the state has actually come to counties and said during this time of COVID, they've seen a challenge for a number of providers, not just at the county level, but with our community-based organizations. And if there's any of them out here watching, they can probably attest to this, are experiencing a greater challenge with retention. We know that has been a challenge a lot of times for small counties because they tend to be in rural areas. People come in, get their experience, get licensed, and then move to maybe the higher paying county or the larger area or someplace nicer than where they're at or whatever it may be. And we're already in a mental health shortage area, and then we're now also seeing that. So some of it is burnout, some of it is people get licensed and now they have more opportunities. They can go into private practice, they can work in other areas. So there's a variety of reasons that the retention is an issue. But the state is saying we may be able to utilize some of our WET plan dollars now to also address retention. So it could be, giving someone, maybe an extension on their loan repayment if they stay longer or things like that. So those will be being developed on a regional scale, but that'll be information that'll be available in the updated WET plan. And with that said, I'm going to stop talking and turn this part over to our individuals who are either on the chat or joining us live from the Webex. If you have a specific question, if you just have a comment, that's great too. Brian, are we recording this?
We are.
Okay, so just a heads up for everyone, we didn't announce that earlier. We are recording this, and the benefit of the recording is that if you make a comment or a question, it'll be a way for us to capture it, go back later on and make sure that we are able to address that and visit it. I'm going to really try to limit answering the questions or kind of commenting like, oh, we already have that, because I want to allow for this to be more of a listening session. But if we need to provide some clarity, or if I want to understand more, then we'll engage in a dialogue. But I really want to reserve as much of this time as possible for anybody who may have questions, comments, or want to provide any input.
Okay, and just one thing to note, there is a pretty significant delay on Facebook.
Okay.
I think it's about 1 to 2 minutes.
Okay. So if you guys didn't hear that, there is a delay on Facebook by about 1 or 2 minutes. So definitely from this point on, we'll slow down to make sure that there's time for people who are viewing it there to view it and be able to get caught up with us, to ask the questions or to type in their comments.
And with that, can you please elaborate, because we heard that AOT was not going to be funded by MHSA.
So the AOT will not itself be funded by MHSA, but once you get an individual that is being referred to a program, they have to go to a program. And instead of creating a whole separate treatment program just for the AOT, and AOT is usually going to start at the higher intensity, it makes sense to try to get somebody placed in an FSP, because the FSPs, we have them based on different population, different needs, and the FSP will provide not just the treatment, but the full wraparound supports and services. So there won't be a MHSA funded AOT. It'll be parts of AOT, and then the treatment parts, we want to leverage existing MHSA. So it won't be, we won't be using MHSA to fund it. We're going to use existing MHSA and leverage those to support parts of the AOT. And if I'm not doing that justice and explaining it, it's because I'm probably not the best person to explain it. We've got some great folks from our clinical ops who have been working on this for past few months on a number of webinars with the state, as well as engaging several counties that have had successful AOT programs thus far. And so they've been collecting the information. I just listen in on the calls and may not be the best conveyor of that information. So if it's not, and we need more info, we can definitely not only just address that, but part of the AOT process is going to be having multiple community informational sessions, listening sessions, things like that. So hopefully in those we'll be able to explain more the nuances and the details for the AOT. Great question. Brian, I'm going to tell you, this is weird because I hear myself in this. Yeah. I hear my own echo. I apologize for all of you that are having to hear my voice, because now when I hear it, it's not soothing.
Our new question is, will AOT be in the MHSA annual update?
We may reference in the MHSA annual update that we are looking at leveraging existing MHSA services, resources in the FSP to support those. But I don't know if we can go really beyond referencing that, because I don't know when the AOT part will come to fruition. So I don't want to be ahead of it in writing the plan. And I say I figuratively, we ahead of it. But I definitely think we need to reference it, because that potentially may fill up our FSP slots with some additional individuals. And it also may need us to re-examine our FSPs of, do any of them need in the next couple of years to be expanded or grown to be able to accommodate if there's a large number. I know, and I don't want to get into the AOT too much because that's not my area of expertise, but in working with like Alameda County, the number of people, and they're a pretty large county, the number of people that they had in their AOT grew over time, and I think the most they've had is 20 plus. So we don't know if it'll significantly impact us or not, but those are all the things that our team is working on and trying to understand and address. So we'll make some reference to it for the parts, like I said, that we are aware of the AOT and we may need to leverage some resources, but it won't be called out as its own MHSA program.
Are MHSA services available for people with insurance?
With insurance?
Yes.
Yes, that depends. Again, MHSA is supposed to be the funding of last resort. So if someone has insurance, ideally you want to leverage and utilize that. There are exemptions, right? Exceptions, I should say, and exemptions. Well, both words are correct. They're not the same thing, but both words are correct. Because I'm just looking at anybody out there that's a wordsmith, be like, those are actually two different words, sir. No, I'm aware, but I think they could be utilized in this context. In that, when we talk about prevention services are really for any resident. So when we're talking about suicide prevention, some of the other prevention programs, training, stigma reduction, those are for anyone. So whether they have insurance or not is not really relevant, because it's not so much a direct service, and even if it's a direct service, it's not a direct service that their insurance would be providing, right? There may be some instances where someone has insurance. So when we're talking about underinsured and uninsured, you could have someone that has insurance, but they could be underinsured. So an example I could think of is if you have a insurance plan, but maybe you reside in a rural area, right? And so for you to be able to access a provider using your insurance, you may have to drive an hour, hour and a half each way. And so all of a sudden you start looking at, well, that's 2 hours round trip plus an hour for the appointment. That's 3 hours a week. is that something that's available? Is that something I can get to? Also, sometimes you have to look at some insurance plans where maybe there's a really high deductible that makes it impossible for someone while they have insurance, but they're not really able to afford it. Those would be case-by-case considerations. So just because someone has insurance, they wouldn't be excluded from all programs. And also we're looking for services for the moderate to severe, so the mild to moderate, those are supposed to be served by the insurance plan. So a lot of times the issue may be just with parity and those insurance being able to provide those services. Another way of underinsured is you have an insurance, but there's no provider in that network in maybe the area you reside, or
Our asker particularly mentioned gaps in funding for peer support, wraparound services, and case management.
Start from the beginning?
Huh?
Start from the beginning of that?
The question asker
Uh-huh.
specifically mentioned insurance gaps such as funding for peer support, wraparound services, and case management, which is not covered by insurance.
Yeah, and so those are not necessarily something that MHSA can come in and offset because the case management is tied into the care. Those are things that we're looking at and hoping things like CalAIM and payment reform will address on the insurance side. For us, we have the SB 803 that's finally moving forward. There's been some listening sessions that we've posted on there where they're working to develop the criteria to certify peers. And once peers are certified in California, they will be able to, at least on the Medi-Cal side, be able to bill for certain services. So really allows our peers to become more active participants in the system of care. Case management support, some of those things on the MHSA side. On the county side, we, again, provide some of those. As far as with insurance plans, those would be questions that probably need to be directed to the managed care plans. And I know there's been various legislation over the past couple of years to address some of those gaps and parities, but that's not something that I really think I can speak to or address just because I'm not the most knowledgeable person on that.
Okay. Can you tell us about the new innovation program for underserved, culturally diverse communities that is going to the Board of Supervisors next month?
So we have an innovation plan that was approved last spring that is going to go to the board to be signed off and enacted, and that is the California Reducing Disparities Project Evolutions. So for the past 4 years, a little more than that, there was a phase 2 of the California Reducing Disparities Project, which funded 35 community-defined practices up and down the state, targeting 7 different populations. In Fresno County, we have 3 CRDPs. The ICSI is one of the ones that has the prácticas, atención y prácticas plena.
Atención plena.
Yes, and I know if Dr. G is watching, he's going to be really upset that I didn't get that, so I'm sorry, Dr. G. We have one with the Fresno Center, which is the Hmong Helping Hands, which primarily, so the ICSS program actually targets Latino, Latina, I wouldn't even say indigenous, but the broader Latino youth population. The Hmong Helping Hands through the Fresno Center targets our older API, but primarily Hmong population. And then we have a program with the West Fresno Family Resource Center called the Sweet Potato Project that targets African American youth. So those are 3 programs that are community-defined practices, things that are working in a particular community that are not necessarily evidence-based and cannot maybe replicate elsewhere, but it works there for that community, at least at this time. And so those are projects that we had really looked at. We felt they're viable. We've started them as innovation projects because we're looking at how we can, with community input and those providers, make adaptations to their program without changing the core, the soul of the program, so that they can be better aligned with MHSA funding for future MHSA funding. So that's a contract that'll go to board. That'll be our 8th innovation plan to be active. We are, I believe, the only county who is funding those CRDPs. So there's 35 of them. 3 are here in Fresno. We're funding those. But if you also look at our on our website, the FresnoMHSA.com, you'll see the annual update for our innovation community planning process. And in that plan, there's several initiatives that got delayed by COVID, but that are underway to address some of our underserved populations. So there's a community participatory action research project that we're looking to start up that'll be focusing on African Americans locally. We have a project that we've already started, which is developing and really looking at, based on training, what would be the need for our Black, Indigenous, and persons of color from the LGBTQ community. And if you look on that plan, there's a number of other smaller initiatives that we're really looking at working with specific community organizations that work with specific populations to do focus groups, needs assessment, input to really help guide us in some of our efforts. So you'll look through that, and I don't remember all the names in there, but there are organizations that really know their specific communities, and we felt that they would be a more effective supporter, partner to do some of that kind of discussion and needs assessment or focus groups with their target audience than if we came in as the county and tried to do it. Not only just because some of them may not be familiar with us, or some are maybe closed off for smaller communities, but some of them also has to do with things like language barriers, where it's just not, things can get lost in translation, so it's really better to have those people that speak the language or from the culture and community with. So if you look on there, there's 5 or 6 at least other initiatives that we're hoping to work on this year, which will either inform possible future innovation projects for those, or maybe gaps or needs that are identified that we may need to consider for our future MHSA 3-year plan. I apologize for people that have to listen to my voice, because the more I listen to it in this headphone, it's just, man. And to think I did radio.
Does anyone want to be our first voice comment?
What's that?
But somebody should be our first voice comment.
If they do, you'll have to mute us. That's okay.
No, okay.
And to think I did radio for a couple of years. But it was late at night, nobody was awake. It's definitely not a radio voice or a TV face.
So far, we have no additional comments or questions.
I'm going to just forward the PowerPoint on the screen behind me, just so people will have some time to jot that down. And we're not ending, I'll still leave time because of the delay, but want to remind people, if they have questions, comments, other things. Want me to go this way, Brian? Well, it's in the middle of the screen, so I don't know where I can. I'm going to go off screen now. If you guys look on there, you'll see the email that you can use. You can email us questions, comments. Aaron's going to monitor the Facebook and YouTube chats for about the next 5 days. So if people comment in there, we'll go in, copy that information and save it. But if you have questions, comments, an idea that comes to you later, please use this email. Email us that, your comments, questions. Also, that these are recorded and they will remain on our Facebook and YouTube page, and YouTube is a lot easier to share. You can share it with someone that's maybe a friend, neighbor, family member, someone that goes like, oh man, I missed it. I really wanted to see this or learn more about it. Share the link for the video so they can watch it. And while it's not live, they can watch it, kind of get some of this information, and then they too can hopefully have a better understanding of what's going on, and can email questions, comments, or ideas also to that email, mhsa@fresnocountyca.gov. And we'll be checking that regularly. We'll be compiling all the information and feedback from you all. We will put it together. We'll start kind of making some considerations and just looking at what we can do. What we need to address, I know some of the comments and questions were, making sure that we address certain programmatic and maybe initiatives. And we want to do some feedback sessions, so we want to come back and have live events like this, probably going to be virtual still, and probably in the next month or two. I don't foresee it being super long. And where we can kind of share and say, hey, you know what, this is what we're going to write up. This is, what we heard. These are things that we're considering. So that you all have information well before we post a plan and say, okay, well, you got 30 days to comment. It's like you already know, okay, I know what is going to be in the plan when it gets posted. So you can totally review, give comments, but hopefully no one is caught off guard. And I honestly don't see people being too off guard, because I don't foresee us making a lot of drastic changes to the plan. I think there'll be some specific areas that we'll be looking at, but I think those are things we already even covered with folks. Do we have any other comments or questions so far? I know, like you said, the Facebook one's like on a minute delay. And again, if you don't get a chance to comment today, idea comes to you later. Remember, we're going to have another one of these next week at noon. What day do you remember, Aaron or Brian?
Tuesday at noon in English.
Tuesday at noon. So there'll be another one, same one, Tuesday at noon at English. Probably the first 20 minutes will be the same PowerPoint and me maybe making the same corny jokes, just for consistency. And then we'll go ahead and get into similar to this, if there's questions, comments, things like that. So if there's something you forgot, email. If not, you can always join then. And please share with people that we do have one in Spanish and in Hmong also. Our MHSA page, Fresno MHSA page, is in English. We are working, I think by next week we'll have a Spanish video up that'll also share some of the information that are in those videos on that page currently in Spanish. And then we also, for you guys that don't know, we do have a full page in Spanish, which is DBH Español. If you go to dbhespañol.com, it basically takes information on how to access care that are on our children's page, adult page, SUD page, and really condenses them into one page so that our Spanish-speaking community can go on there and get the information they need versus trying to hop around our website. The county website has a drop-down menu where you can use the Google Translate to translate it into umpteen languages. The drawback with that is the Google Translate does a little word for word. And so things are lost in translation. It's not always the best way to convey. And so what we did for this one is we took content that was already on our website, pulled it together, had it formally translated by a translation agency, had staff review it, and then we created that page with a specific URL. So if someone is Spanish speaking and wants more info, DBH Español is also another way that they can get info. If they need to email, people can email MHSA Fresno in Spanish. We will then print it out and have our staff assist us in translating it so that we can get that information as well. So please don't feel left out. We're doing everything we can to make sure we get every voice and every comment in. Do we have any other questions, comments?
All right. Just a question.
Okay.
There are a few innovation projects now. In the future, will the county be able to consider an innovation project that studies nutritional psychiatry approaches to addressing depression and anxiety?
That's definitely a possibility. Those are things that we can always present to our stakeholders. The things that we are looking at is we probably have more active innovation plans than any other county. We have 9 approved, 8 that are set to be active. When you think about every innovation plan, there's the actual project and the evaluation. So for our team, those 9 innovation plans actually translate to like 18 different contracts, if not more. Like our CRDP evolutions, there's 3 different providers working. So even though there may be one like master agreement, you're dealing with 3 different programs under one project. We have a justice project that we're working on finishing up. And so as soon as we get some feedback from the OAC, we will begin some community planning processes with that. So that would mean potentially by the end of this fiscal year, we would have 10 approved innovation projects with only 1 completing. I think 1 will be done at the end of this year, which means we will be still back to 9 active plans and having a look at. So we're looking at plans, but we're also really trying to be cognizant of what is our capacity to lift up the programs and actually get them done, because we don't want to have a bunch of programs that are approved and then they're sitting on the shelf because we can't start on them. We also on the same hand can't not do programs because we also don't want to risk reversion with some of those funds. So we're having to really make strategic decisions in terms of not just what are great ideas and projects, but really what is our capacity to do this. Because like I said, we have a couple of staff handling those. which in probably some other counties would be split up between maybe like 4 or 5 people, and I think between contracts and our team is like 3 people handling.
Can you
18
describe how an innovation plan goes from a little bit of a seed to a full innovation plan?
Yes, I'm trying to think of how to do it in a short, quick way. So like the question that was brought up today as far as the nutrition, that'll be something we'll write down. That'll be something that we'll probably come back and have some additional discussion of, is that something we want to explore, as well as a couple of other innovation plans that are in the pipe. So if you look at our current 3-year plan, there's a justice project, there's still a potential youth by youth for youth project that has not been fleshed out and brought on up to speed, and then there's still a potential training development with Bex that I believe we still have in there. So in addition to one we're currently writing, there's 2 more that are already in our MHSA plan. So if we were not going to go forward with those, we would want to come back and really discuss it with the stakeholders in terms of why we're not going forward with those, and then potentially discuss ideas for new ones. So if there's an idea and it seems like it has some traction, we'll work on developing what we call a concept paper. At least this is how we do it in Fresno. We'll develop a concept paper, try to, in a couple pages, kind of flesh out and really address initially some of the innovation regulation questions as far as what's the learning, what is going to be the benefit, what is the intent. We'll also want to look at is that something that is aligned thus far with our stakeholders, and making sure like we're not skipping some of the other things that have been addressed and requested by stakeholders. So we'll write that up, get those to the OAC. Right now, it could take them about a month or so before they're able to review and get back. And our concept papers are 4 or 5 pages long. If they feel that it potentially is a innovative project that would meet requirements, that it's an idea that can stand on its own, then they don't want to officially say yes, but they will say, okay, we'll continue to develop this. And that's when we then come back and start getting some input depending on the project from the community, from our stakeholders. Then we start to develop the plan. Once we have a plan, we then do either we'll do a public hearing at the beginning, or in some instances, because they're plans that have been around for a couple of years and we just weren't able to start working on them till recent. Those ones we've written up, then we start the 30-day comment, the public hearing, things of that sort. So I'll go back to some of our previous innovation projects. One like the lodge, that had been in the previous 3-year plan. It had been there for a minute. When we started lifting it up, we went out because it was of the nature of the program and actually spoke to programs and providers that were providing services for unhoused or homeless individuals. We went to several shelters and actually spoke to individuals who had experienced homelessness. We went to our wellness centers and spoke to our peers, as the program was really looking to have a strong peer component, and really talked to them and got some feedback from individuals who are served but who had experienced homelessness, and really gave us input. And then we were able to develop a plan. Same thing I think with our Ride Well, the transportation program. We did some focus groups with some of our community partners and vendors. We looked at what were service gaps, met with transportation entities and things of that sort to really help flesh out. So it depends on if it's something that's already been in the idea has been in our plan and it's now a matter of moving it forward. We'll have maybe one approach. If it's a brand new idea that has not existed, we definitely need to, I think, bring that and have some discussion input. And then the biggest thing for us is also looking at, okay, well, can we implement this program and can we sustain it? We do prefer right now to focus on research and learning projects, because once you're done with a research project or some type of learning, you have that information. You can now go do the next step with it, versus when we try to create programs with it, then you're faced with the challenge of sustainability. How do you sustain it? So we definitely do, would say right now we're starting to lean more towards learning projects, but that's where we're leaning to. We still have to have that conversation with you all as the stakeholders and having those discussions, and then hopefully being able to help everyone understand why we may be taking that approach. Because like I said, if you have, let's say, $1 million innovation program, it's $1 million a year. Well, at the end of 3 years or 5 years, do you have the revenue and the funds to fund a program that costs $1 million a year? Versus, maybe you're spending $1 million over 3 years for research or a pilot or something like that, then at the end of it you say, hey, do we have enough information to keep going with this, or do we go a different direction? Or could that information help us improve or, launch something else? So that would kind of, I was going to say nutshell, but that's not a nutshell. It's a long way how we have been looking at and how we've been doing our innovation projects. Ow, my back. What time is it, Brian?
5:54.
All right. Yes.
All right, one
We're still on.
question. Sorry, I gotta scroll up to it. Can MHSA help facilitate the implementation of integrated care for things like cancer and brain injury in children?
I have not heard that being done. I have not heard that be a discussion in the past. MHSA has had really specific parameters in terms of what it does until legislation that was just signed by the governor. With the exception of some co-occurring programs, we could not even touch like SUD, so we couldn't really integrate in that area. And so recently with the legislation that was approved, signed by the governor this past month, we're able to now utilize some of our PEI dollars to do some prevention work and be able to support some SUD service board. Like I said before, it had to be specifically a co-occurring or we could not use it. Right now, things under the, for example, autism spectrum are not things that MHSA can be utilized for. So I think some things that we're looking at in terms of primary health needs, whether it be cancer or traumatic brain injury, some of those other things right now I have not heard. I should take that back. I've not heard them being used in that regard because I don't think anyone has made the correlation connection with mental health and really the intent of MHSA. I know some counties have been able to use MHSA to do, and I think with San Bernardino through an innovation project to address eating disorders. And because that one has a medical component but also a mental health component. So that's probably the only one, but I'm not familiar in the past 10 years any counties being able to, or and that's something Aaron will dig through the regs, but I have not heard, I just don't remember seeing the words medical in many other regs, so I don't believe it's a approved use for the fund, but we'll check and make sure.
And then the last thing I have is that the FresnoMHSA.com link is not working for some people right now. So what I will do after this stream is I've posted it in the Webex, and I will make sure to post the direct link without the vanity URL on YouTube and Facebook so that people have access, just in case the vanity URL isn't working for anyone.
Because that's how I find a page always, whether it's my phone or computer. I cheat and just use the FresnoMHSA.com. Make sure you're spelling it right. I know for a long time I used to reverse it or invert it. I'd do MHSA Fresno and it didn't work because I wasn't using the right one, Fresno MHSA. So yeah, just double checking. Some of it could be the firewalls, depending on where they're using it. But yeah, just if you can, we'll add that other in the chat so people can get a direct way to it with, that way they can just click on over. So I want to type the super long link. Any other question? Brian, what time are we at?
5:58.
All right, we got about 2 more minutes. Normally these are about an hour and a half. For the virtual, we're doing them at an hour because in person, I don't know if it takes longer, but we tend to have more dialogue and it uses a little bit more time. With the virtual, we found it doesn't eat up as much time. We do try to keep our presentation, like I said, to about 20 minutes. I don't know if we hit that goal, but that's what we were striving for, and to really make sure that we maximize the amount of time that people have to speak. So, and again, this is not your only time. This is just a time where we're live, but you can, for the next 5 days, post questions, comments in the chat. You can always email. We'll have additional of these CCPs, and hopefully in a couple weeks to a month, we'll also schedule some feedback sessions. So the questions that were asked about the medical and some of those other things, we'll hopefully be able to report back and respond to those as well.
You have to wait just 2 minutes before you end.
Sorry, I thought that'd be funny. People would be like, they're frozen. We're going to give it a minute or two, Brian said, just so we can make sure everything gets caught up with some of the other platforms. Again, mhsa@fresnocountyca.gov. Email us questions, comments, put them in here over the next 5 days or so, and we'll monitor the chat and save those. And again, hopefully all the questions and comments we got, if we didn't answer it here today, we'll review those and make sure that we also answer those when we have those feedback follow-up sessions. I feel like a football coach with the headset. All right, thank you all. Have a good evening, and we will hopefully be in contact with you at our next virtual here next week.